Hey guys, how are you?
Good morning.
Good morning. Welcome to NYU Langone Health System. Thanks for having us. Congratulations to Dave Reisig and the Planning Committee for another successful SIF. Congratulations to my good friend Jim Hermiller for winning the Lifetime Achievement Award. We've got a great case for you. I'm here with my colleague Luai Razzouk, Master Interventionalist, our Interventional Fellow Aaron Flattery, who we're thrilled will be joining our faculty next year. In the room, we've got Renee and Julia, and out on the monitor, we've got Christine. We also have Jonathan Hicks from Boston Scientific here. So I'm going to turn this over to Luai to present the history of our case, and then we'll ask the panelists for their recommendations here.
Great, Sunil.
Thanks for the introduction, Sunil. Next slide.
Oh, geez, I don't know how this slide got in there.
Come on. Where's the Michigan score? How much did Michigan beat Ohio State?
I don't know. I think it was hacked or something. Sorry, go ahead, Laura.
Let's go next. So this is a 7-year-old gentleman. Thank you for inviting us. Thanks for the intro, Sunil. 7-year-old gentleman who has exertional angina relieved with rest with really minimal exertion. He's got class 3 angina. He's got hypertension, hyperlipidemia. He's a former smoker. Prior PCI to the mid-RCA in 2007, and he's on good medical therapy, well-controlled blood pressure and heart rate on aspirin, statin, fish oil, and also beta blocker and a calcium channel blocker, as well as an ACE inhibitor. He had an echo that showed normal LVEF with no significant wall motion and valvular heart disease, and he went 5 minutes on the treadmill, had angina on the treadmill, no EKG changes, and had ischemia in the LAD and circ territory. So we can go next and go over the diagnostic angiograms. This was performed by one of our colleagues. Showed that the mid-RCA is a dominant vessel, moderate lesion in the mid, right at the level of the prior stent, and a severe diffuse PDA that may have to be addressed in the future. The left system, there are actually no stents in the LAD, so this is all calcium, and it shows a severe small caliber OM1 and a severe distal circ. We can go next as well. With a lot of calcium in the prox to mid-LAD and a severe, about 90% mid-LAD right above that diagonal. On the spider view on the right, you can see actually that there is some disease in the ostium of the LAD. So I don't know if you want to kick it to the panel and see how would people approach this.
Yeah, why don't you just go to the next slide while people are gathering
I
their
was
thoughts.
telling everybody in the room.
So we lost
Hello.
by the way. So we have a gentleman who's 70, has triple vessel disease. His syntax is in the medium range, 23. We did a syntax 2. His mortality with PCI and CABG are similar, about 9% and 7%. So we actually presented him to the heart team, offered him surgical revasc. He declined, so he's being referred for initially PCI of the LAD and circumflex.
Yeah, so what does the panel think? I mean, the circumflex lesion...
May I make a comment, Sunil? Sunil?
Yeah, please.
May I make a comment?
Yeah.
I wish, first of all, you'd focus a little bit more on the case than, some second-rate football team. That's the first thing I would say. But I do want to congratulate you and the Ohio State Buckeyes on what was a nearly flawless season. Nearly flawless.
Yeah, there was something that happened in the middle of that season. I can't remember what it was.
Okay. I hope it was an inspiration to you. We're doing a clip right now. I'll catch you up later, okay?
Sounds good.
Sunil, so Dave here, one question. I guess I'll sort of have Bill start off. The findings of the stress test matter in terms of our interventional. I mean, we only have, if I read that right, only anterior ischemia, right? So why intervene on the circ if we don't have anything?
It was inferior as well.
Inferior as well. I'm sorry to miss that.
Well,
Okay.
No, I think your point is a good one, and I think that at least what we're seeing in our practice is a lot more CTA and CTFFR rather than stress testing. And I think that's because, stress testing, you'll get sort of what the worst area of ischemia is. It doesn't necessarily exclude other areas. And of course, I think all the data that we have around complete revascularization suggests that, it's really anatomic based, right? Even the ischemia trial showed that it's really probably anatomy that's starting to matter a little bit more than ischemia. But of course, we got to put it all together and do what we think is going to be, the best outcome for the patient.
Okay.
So our strategy is to really try and achieve complete revascularization here.
Great. Bill, what's your next step? We'll start with you.
I mean, I would trust whatever Lou wants to do. I mean, there's a lot of different options. LED, you could do atherectomy. You could see if an IVUS across goes straight to shockwave. If the IVUS goes across, maybe it's not circumferential. You don't know. So I think it's really, you got to get in there. And, you know, for me, it's wire, IVUS goes. You get to decide what to do. IVUS doesn't goes. I would do either orbital or rotational atherectomy at the operator's discretion and then move on from there. And I think that a lot of this goes down to is image-guided PCI changes the outcomes, and then we've never had a trial of medical therapy versus image-guided PCI. We've never had a trial of surgery versus image-guided PCI, and because of that, we stand on a lot of very inaccurate data.
Yeah, I think that's a great point. And this sort of mirrors kind of our approach that we take here at NYU as well. You know, we do a lot of imaging and then base our prep strategy on the results of the imaging. So
you can see it now, actually.
Yeah, here's the, so Louis, you want to describe our sort of vascular access approach here and what we did? Sure.
So we did ultrasound-guided radial access. He had prior radial access, so we just want to confirm that the size was actually pretty good for 7 French. There's, you know, we like to have 7 French whenever we're going to do possible atherectomy. It gives you a few more options. And we can start with the first shot, if you don't mind, Sunil. So we ended up, you know, doing a little bit more fluoro and saw how much calcium there is in the LED. Again, one more view here. Based on, oh, this is the last one. Yes. And so our plan is, because there is a possibility of going back to the left main based on the spider, and we'll show you the IVUS in a little bit, our plan was to actually fix the circ first and then deal with the LED afterwards. I don't know if the panel is okay with that or not.
What do you think, Kari?
Yeah, I think so. The first comment I have is there's a lot of diffuse disease here, someone who's been stented 20 years ago. And so I think the initial discussion with CABG is still relevant because there's probably a lot of progression, even if you get them on good medications. But at this point, if the patient refuses, then now I do agree there is osteal LED disease. You're going to have to document that on IBIS, but then I would go down and fix the circ first and then come back, yes. The first OM also seems pretty diffuse disease, and it's not that small.
Yeah.
We agree, and it's not that small. The only drawback with the OM, Hari, is that, I'm going to go back for a second, is that the circ is a little disease at that level, and we IVUSed it actually, and we got a good MLA of 5.5. We got also an MLA of 5.5 at the ostium of the circ, so we decided to do provisional for now, at least for the circ. We're going to re-IVUS later. So we went ahead and IVUSed the circ. I would love to show the IVUS if possible for the circ because I think there's a little bit more calcium than we expected. So we can play that, yep. John.
Go ahead. So, yeah, this is our first IVUS run.
Yeah. So this is pre-treatment.
And this is of the circ, just for the audience.
This is circumflex, yeah. You can see at least 270 of calcium. There's 360. You can see that it gets pretty tight. Yeah, 360 again. So you know, I'm still old school. I like to try NC balloons first, so and see if they expand. I think also it's helpful, and we'll show you how we address this calcification. We actually re-IVUSed after our initial set of dilations to make sure that the calcium is fractured so we can get good stent expansion. And there you can come back here.
And the reason you're thinking that is cost, or the 360 you think you can break?
Yeah, I think it's a little bit of both, right? I mean, you know, we're all under a little bit of pressure for costs now. You know, I think a lot of these calcium modification technologies are incredibly helpful, and you know, we'll show you the result of the circ and show you what we did on the LED as well before we get back to work here. And I think it's really kind of, we try to tailor the calcium modification strategies to what we're seeing on IVUS, and you'll see that when we get to the LED shortly.
Can we play the IVUS now, post NC balloon? So this is the second IVUS.
Yep.
Yep.
And how high did you guys take your NC? 14, 16, 18, 12?
We took it to 20, actually.
20, okay, great.
Yeah.
So we Yeah, we took it to high pressure, and you can see here that there are some areas that actually got fractured, but there are some parts that did not. And so you can play that a bit more, John.
You can see some fractures there.
see it there.
1 o'clock, 7 o'clock.
Zero again. Zero again. Zero.
0.
So Sue Deschner, looking at that, what's your next step thinking? I'm just curious.
I think it's really important for everybody to understand that you have to IVUS after any technique that you use for a calcium modification to see if it's successful. And here it looks like there is some cracking of calcium, but there is still some that was untreated. So regardless of cost, I would probably go with intracoronary lithotripsy to get a better effect, and so that we can have good stent expansion.
All right, we'll see.
That's a
Interesting to see what these guys do.
So we took a 1-to-1 cutting balloon, actually, and it looks like it yielded here. And actually, we go up on the cutting balloons pretty high, 14, 16. This one actually was a 12, and it kind of yielded. There's a little bubble there, so we repositioned it. And so we felt pretty confident that this has yielded. And so then we went on and took in a 30 by 38 stent, and then fixed the circ. You'll see that in a second. Took another 1-to-1 NC balloon, now a little bit larger. And then IVUS. We can show the IVUS if you'd like while we play the angiogram, John.
Okay, do you want to show the final IVUS of the circ? So as you guys know, there is a randomized study going on between cutting balloon and IVL. So here's the result of the IVUS on the circumflex.
Sarah, Shonda, you happy with what you're seeing there?
Yeah, I think it's a reasonable result. It looks really good. I would look at the entire length of it, and if it's well opposed, it definitely doesn't look underexpanded or malopposed at this point. Maybe some post-del there in the proximal segment, but overall, I think it looks like a wonderful result.
Pretty great.
We were very happy with this,
Yeah.
and we were getting expansion rates of 90% or so, no distal or proximal edge dissection, and good apposition. So then, now we turned our attention to the LAD, and while we're showing you what we did in the LAD, I'd love to hear from the panel about how they want to deal with the circumflex here, because why don't we show the IVUS of the LAD, Jonathan? Because I think what you'll see is the ostium of the LAD is going to be an issue here. And even though angiographically it may look moderate, you'll see it really ends up hugging the IVUS catheter with a pretty thick ring of 360 calcium. So you're seeing the IVUS on your screen there, and you can see islands of very severe calcification.
And that was done after a 2.515 balloon, just to be able to deliver the IVUS into that super tight spot.
So this is the ostium of the LAD where it gets narrowed again?
Not yet. This is actually the prox LAD. You'll see the ostium towards the end of this run here as we get into the left main. And I think, not to steal the punchline here, but I think we're going to have to come back into the left main on this case.
Yeah, I always get
here as
in
it comes
trouble
back.
when I start thinking the angiogram versus the IVUS, but you almost got to
Right there.
trust your IVUS,
That's
right?
ostium.
So what are you getting there?
Yeah,
Yeah, what,
That's the wire from the circ.
yeah.
Yeah.
Is your MLA there?
I
do you
think it
mind
would be
just-
nice to have an FFR across that proximal LED.
Interesting. So you would FFR, Tim, rather than use the IVUS to tell you to intervene. That's nothing wrong with that.
Yeah, I think, it's a good point around sort of the FFR. I guess our sort of thought here is that, you're getting an MLA here of 2.9.
Yeah.
It's a prox LAD. I think angiographically, we're not going to be very satisfied with it either, even if it's FFR or DFR negative. So our plan, well, let me ask the panel. So here you see the angiogram, you see the IVUS. What would the panel do? And then we'll tell you what our plan is.
Dr. Bailey and then Dr. Gupta, would you fix the prox LAD or not?
Well, you have anterior ischemia already on a non-invasive test. You've got a lumen there that is
both by length of disease and severity of disease, I think is significant. So I feel like I'm committed to fixing it with that information.
Dushyant? All right, so I think we're in agreement, Sunil.
So my mic was not working. So I think it's more bigger problem, which is your osteal left main, LAD, and you don't have any landing zone. To me, I think that will be your critical thinking here, especially to stent that. Now you have a bifurcation lesion. You got to deal with the whole LAD and left main system right now. So yeah, I think you do tackle that all together.
So I'll turn it over to Luai to tell you what we did with the LED, and then in the meantime, maybe the panel can start thinking about, what that bifurcation strategy they would prefer in the left main ostium, the LED, and the circumflex. I mean, the circumflex ostium, the MLA there was 5.4. There's plaque, but it's not severe by MLA. So, Luai, do you want to talk about how you approach this LED?
So to your point, Dr. Cox, we actually went up to 1820 atmosphere here and actually yielded for the mid spot with an NC balloon prior to delivery of the IVUS. So that's why you see probably some cracks initially distally. And then we were deciding between wanting to do shockwave versus orbital versus rhoda. Given the size of the vessel, we felt that shockwave would probably make the best contact. So we ended up taking a 3.5 shockwave after IVUS. And the vessel is about 3.5 above that diagonal. And ended up taking actually about 30 or 40 pulses, and the balloon ruptured. So this is the 3.5 shockwave balloon. You can see that it's underexpanded proximally.
And it ruptured at just 30 or 40 pulses. Interesting.
Correct. Very early on.
Here you can see it cracking. There, it's expanding.
And we don't even go to 6 anymore. We just go to 4 and then give the shocks. And there's a little dissection there that you can see right at that septal. So we took a second shockwave balloon, and we were in the midst of doing that. And so this is the second shockwave balloon. We've given so far about 40 pulses, and it's starting to yield, but this is where we're at finally right now.
Wow. Sunil, you always get mad at me when I tell you I use 2 IVLs, so it's kind of making me feel a whole lot better that you use 2. So,
Luai gets whatever he wants. So it's,
all right. Bill, I'll come back to you. What's the next step now? Is it IVUS or is it something else?
Yes.
Yeah.
Again, I mean, we're trying to take something that's really pretty straightforward and make it way more complicated than it needs to be.
Okay.
And I think there's a million different ways to do this. We get caught up arguing over the details, which really, in the grand scheme of things, don't matter. I don't care what you do. Expand the stent, open it. You could defer and do physiology to see if the osteal LAD is real. You could go ahead and stent the left main LAD. It's a really simple, straightforward thing. The left main is not a Sankers, special vessel. It's the easiest vessel we have to stent with the lowest restenosis rate because it's huge. So you could do a million different things. I trust Luai and Sunil. They can do whatever they want. I mean, I don't have a great answer because there's 20 different ways to do this. The important thing is maximize the stent size and get complete revasc. If you do that, you beat surgery in this patient.
So I wouldn't disagree, Bill, but I'll disagree a little bit. There's 20 ways to do this, but I think your comment on the opening session is I'm trying to be better. I need a coach. And Sunil is coaching me how to do this case right. And I think what I'm getting from this case is you can't make decisions without imaging here.
So I have a question. So if we fix the proximate LAD, and what about doing the physiologic testing on the ostium?
Yeah, I might go with that because we're not so good at MLA versus IFR, and I think it's reasonable, especially because it makes it more complicated. Even though left main is relatively easy and you could do provisional right into the LAD, you may not want to do that if it's negative and defer and see how the patient does.
Yeah, so you have the final call, Sunil, but the panel's kind of thinking about FFR after the LAD's fixed. I don't know if that's right or wrong.
Yeah, I think we're not going to do that. I mean, I think,
respect that.
I think we're going to sleep better at night knowing we have a really great angiographic result in the ostium of the LAD there.
Understood.
And we've got anterior ischemia, if there's one great correlation between physiology and and another test, it's nuke. And so to me, it seems like 4 atmospheres. I think we're just going to sleep better at night if we just fix the ostium of the LED. And I totally agree with Bill. I think that simple is always better, and maybe that's my age talking, but I think that we do tend to sometimes overcomplicate some of these decisions. Yeah. And here, again, for our approach here is going to be a simple crossover approach. We've got a wire in the circ. We're going to wire we've wired the LED. We're treating the LED, and then we're going to just stent across it, and then do what we need to do in the circumflex. Going up. The question I guess I have for the panelists is that we're finally now in the United States living in the DCB era. Would anyone DCB this circ?
Kim?
4 atmosphere.
Well, I would have fixed the mid-LED, and then I would have done a high power across epox.
Okay.
I'm doing just part of a trial, but a lot of combination OCT and physiology. Frequently, they don't agree with each other.
Interesting. But would you, I guess the question Sunil's asking us is, given that he is going to fix the LED, would you DCB the osteal circ or not?
Oh, there's no disease.
I would not. But
Why would you do that? There's no disease.
I would do the LED first and then look at the ostium of the circ. And
the key in this is bring the stent far enough back in the left main so that you can pot it with an 8mm balloon. So the mistake most people make in this is they try to get cute. This is one where you bring the stent almost back to the ostium of the left main, just stent across and jail it. At least I assume that's what Levi is going to do, knowing his background, but this is one where you really want to make sure you just give yourself lots of left main stent, because it's probably a 5.0 left main, and it'll do well.
Yeah, that's a great point.
Is that your plan, Levi?
Yes.
Too often you'll see people try and put it just a millimeter into the distal left main, and then all sorts of bad juju happens.
I think that's a good.
All right, so what are you doing here, Sunil? 3.5 pre-dill?
This is a 3.5 shockwave.
Shockwave to the
Let's
LED.
IVUS now.
Yeah, so now we're going to IVUS again just to make sure that we've got fractures in the calcification. We're going to confirm our distal and proximal reference diameters, and then I think we'll go ahead and stent.
And you guys decided to just make this effectively one long contiguous stent. It looked like
Right.
Exactly.
You could have gapped them, but you guys decided you're just going to, put a metal jacket in it, right?
Yeah, I think so. Yeah, I mean, this is all contiguous plaque, right?
Yeah,
I mean,
okay.
it's all the same plaque.
Yeah, there's no area
There's
to
really no
skip
healthy
here.
spot in the middle to stop, honestly. So that's the reason why. And to Bill's point, on average, we do about 2,400 PCIs at the main campus alone. We do probably about, I would say, 4 or 5 left main PCIs on a regular basis per week. And we have a very strong surgical program, but we really also have, as Bill said, the data for left main stents is pretty solid and robust.
So that wasn't your third shockwave. That was the second shockwave that you saved from pulses on, right?
There's a moratorium. If you're doing more than 2, then there's a problem. Yeah.
Just want to be clear.
Yeah. Even you don't get 3 days.
I like, Sunil, I love the fact you brought up cost. You dropped 2 shockwaves, and then you talked about DC being the circ.
Right.
There you go.
Right, it took my cath
They have their DCB quota, not yet.
Yeah. The cath lab business manager's knocking on the door.
What do we got here, guys?
Yeah, we're just, the wires may have gotten a little tangled here. We're just going to. So that's interesting.
Interesting.
And
Very
the catheter
interesting.
may have gotten fatigued a little bit here, too.
Yeah, let's get a new catheter if you don't
I'm
mind.
glad this is
It's actually
happening,
local.
because this happens to me more frequently than I want to admit. So,
Yep.
Sudeshna, what's the move now? You're trying to
Yeah, I think
get
it's
it
better.
down, and it won't go.
Well, you could, that's a good question. You could use a guide extension. You could take a second wire, which is what they're doing. Work as a buddy wire, or it can help you get a different rail and change the angle.
Wiggle wires help here or not? I've not used them a
I've
lot.
not used it for this.
We love wiggle
Potentially.
wires.
All
We
right,
love wiggle
so
wires here.
we got the wire back down the circ. What's your move, Sunil?
Yeah, I think we got a little bit of catheter fatigue on this IVUS, and we've already done several runs, and so we're just getting a new catheter here so that we can deliver it.
Okay.
I mean, these are obviously very low-profile, short RX systems, so.
So the question to the panel is if we find some cracks, but we're not totally satisfied for the ostium of the LED left main, would you take a bigger shockwave balloon, or would you try a cutting balloon at this point?
Pays your money and takes your choice. So the question is, if the IVUS doesn't show that it's cracked, what's the next move? A larger 4.0 shockwave or a cutting balloon that's higher up? Steve, what do you think?
I think at this point, I just don't know how much a cutting balloon is going to get you over that. You already, have used shockwave. You saw some benefit from it. I think I probably would continue with shockwave at this point.
The other one I would throw out there is OPN exists too.
0.
So OPN would be another option. I mean, the thing is, I hate to tell Shockwave this, but Shockwave doesn't work in every case.
Yeah.
And OPN doesn't work in every case, and cutting balloon doesn't work in every case.
Right.
And unfortunately, in some cases, you're going to have to bring everything to the table to get it fractured. So, there are a lot of different options for this. So the other piece I would tell you is if you're doing Shockwave without image guidance, you're wasting your money. Because if you're putting too small a shockwave in, you're not going to get an effective fracture. And so just please stop doing that.
Bill, do you put the shockwave in 1-to-1 angiographically, 1-to-1 IVUS?
1-to-1 IVUS. Angiograms don't tell you the size of anything.
Okay,
so you go in on IVUS, you look at EL to EL, and you try to size it to that.
I think that's an important point. I think people don't do that as often, perhaps, as they ought to. Because you're only going to 4 most of the time, so.
The whole point is it has to be opposed.
Exactly.
Otherwise it won't work.
The 4 also, though, is a bit of a misnomer because when you actually deliver the shocks, you're going to 60 to 80.
Understood.
It just, the number makes you feel comfortable.
Exactly. So what do you think it's hanging on?
I think there's a little dissection flap there that we're just getting hung up on.
We'll take a little picture.
Just not getting a lot of push here.
Yeah, you could try and change the guide angle. Sometimes that'll help get the catheter off of it.
Yeah.
Bury
That's
your
exactly
wire,
what we
you
just
balance
did.
it a little bit. I've seen people take monorail balloons and put them behind the IVUS so that you can push
right.
harder because the rail's so short.
Oh, that's interesting.
So there's a lot of potential. You could do a body wire.
It's a buddy wire.
So let me hear that once more, Bill. You can put a monorail behind the IVUS catheter?
Yeah, you just take a,
Let's get this.
you take a 2.0 monorail on the same wire.
Okay.
You push
2.0
it down
by
and you
20,
make it a tandem force.
2.0 by
Jared
20,
Frizzell taught me that trick.
Right.
Sometimes it works.
Yeah.
It's like every trick, 60% of the time, it works every time.
Yeah. I actually showed that slide yesterday.
I think that's a great trick. Bill learned that from Craig, and actually I like it because it makes, from Craig Thompson, it kind of makes the catheter a bit stiffer.
Exactly.
And the other option is to do, obviously, a 5 French IVUS inside of the 6 French guideline or
Also
a
really
telescope.
frustrating.
They never pulled that additional wire back.
So I think what is important is that Sunil and his team are not
Yeah.
quitting. They're doing everything they can to get the images. And I think we all have to do that too.
In this case, I think, IVUS is going to be incredibly helpful here for our final result, which is make sure that we get the expansion that we want.
Do you guys, you got the 5 French IVUS or the 6 French IVUS? Because that obviously, if you're going to use a guide extension, affects what guide extensions you can use to get it delivered.
Yeah, so it's 6 French IVUS. We do have the 5 French IVUS available, and so we can probably either. We also have a 7 French guide. So if we want to use a 7 French guide extension, we're able to use a 6 French inside of it.
Or a 6 French liquid would work too. You actually can get the 6 French IVUS through a 6 French liquid.
Yeah. Well, I'm really hoping that next time I see Bill in person, he gives me a hug for that Class 1A recommendation for intracoronary imaging.
I am going to give you a hug. Thank you.
Thank you for a hug anyway.
Thank you for having courage.
That's right.
I hope that people actually start following the guidelines. That would be even more helpful.
Yeah.
Yeah.
So we're doing this thing that Bill brought up, which is where you put the balloon actually behind the catheter.
Interesting.
It doesn't look like it wants to go. So I think we may want to just balloon the LED. Let's get a 3.5 by 30 NC emerge, please.
Right. That makes sense.
I think we just need to balloon it, and probably we'll go after that.
Yep.
I would just put a guide extension in. That's the guarantee way.
Is that right? Okay.
Yeah, because I mean, if you take, you're going to go balloon it anyway, right? So you take the balloon with the guide extension, you balloon, inchworm it, and you get it across. That way you guarantee the IVUS is going to deliver. It's sort of, you know, it's getting about efficiency. You could try a bunch of these halfway measures, but at this point, you ought to just go to the full measure, the one that's got the highest likelihood of success.
Yeah, let's get
I think that's a good point. Sometimes we do incremental things, but if you can do a couple things at the same time, you maximize your chances.
Yeah,
for
7 French telescope.
Yeah,
7 French. Oh, we have it?
he's opening it up.
Yeah, got it. Yeah, so we're going to put a
Plus
7
it'll
French
save you
telescope
fluoro and
in.
contrast, so.
So what's your choice of
fluoro and
extension, Sunil?
We use a lot of telescopes here, but you know we also use trap liners for our CTO procedures when needed.
We don't have the liquid yet. We met with Chad, and it looks very promising. And at CTO Plus, it seems like everyone is using liquid, so it seems like something that we may want to get. Luckily, the director is next to me, so
Yeah, the problem is the director is just impossible to deal with. So.
The only challenge with liquid is it's stiffer, partly because of the bigger OD and just the way that Chad designed it so it wouldn't basically crumple like most guide extensions do. So it feels a little bit different to deliver, but it's nice because you can trap behind it and use it to deliver stents. The problem with trap liner is it's really only good to do your upfront stuff. It's really terrible to deliver stents through. Plus, they're very easy to break off because of the hypotube.
got it.
Yep.
All right.
So we're just going to we're going to balloon it again before we try to deliver the IVUS, and then make some decisions here.
I'm sorry you guys are having trouble. This is actually very instructive for the audience. We're really feeling your pain, but also trying to learn. So it's a great case.
You know, obviously I wouldn't switch over the kind of imaging, but you know, I've become a convert to OCT, and I use the Intuity, which is 2.3 French, and it's really small, crosses everything. I've never had to have a trouble cross pre, mid, or post.
Yeah, it's interesting.
It's
All right,
really-
so what do you have here?
Going up.
So we have a 30 by 30 NC. Let's go up to 14, 16, 18, 20.
18 atmospheres and 20.
So I like to advance it. I learned this from Bill and Craig. And let's go down here, please.
Yeah.
As we're deflating the balloon, it's kind of nice because it seats the telescope nicely. And so kind of to Bill's point, now you kind of have two in one. Let's fluoro save that, please.
Now,
Yeah, so the other thing about these guide
And
extensions.
now the guideliners.
now the IVUS is a win, right? Nicely done,
Yes,
Ryan.
we're just gonna balloon just since we have it here already right by the diagonal, because I think that will give us a little bit more tiny tap if you want, but just very gentle because of the telescope.
Yeah, and I think, you know, it's important to remember that these telescopes and these guide extenders are not just, you know,
A bit more.
tubes on a stick.
I'm sorry.
You know, going up.
I would highly recommend not doing what they just did. Really try to avoid doing injections through guide extensions that are buried in coronaries, because they will not potentially tell you that they're damped, and you can cause significant hydraulic events with them. I've seen both perforations and dissections. So I appreciate why you did and what you did, but
Yeah,
I
I
just,
guess, you know,
in
that's sort of the point I
general,
was trying to make is
I
that,
would
you know, these
really,
things are
really
not just
pause
tubes on a
before I
stick. There is
took
a
a
way to
test
use them to make sure that
through
it's
a
relaxed
guide
inside the
extension.
Yeah,
vessel.
you've been really
If you are gonna
consistent
inject,
in
be very,
that
very gentle about
message,
it.
and I learned the hard way why. And I've sort of
but now I
followed
think
your
we're gonna
rule.
our guide extension is in the excellent position. Eli's going to reposition the wire, and then we'll go down with
It
our
comes
IVUS.
up at the complications
And again, we're
course
keeping an
every
eye on the
year. You'll see
pressure
2 or
as
3
well. We wanna make
perfs
sure,
related to this.
Yeah.
that we're not
So
causing a lot
Bill,
of
you don't, it's so interesting because we used to not inject at all, and somehow I feel like we get away now with these tiny little taps. You don't inject at all, do you?
No, I would never do it. I would just, I would mirror image. I mean, I would go to my setup shots and use the ribs and the spine and other markers to get me roughly where I want to go. But I really, really don't, and again, it's an odds ratio. You're only going to get, you'll get 5 or 6 bad events, but when you
Right,
get them,
right.
they're really bad. It's just not
Yeah,
worth it.
no,
There are
no
other
doubt
ways to
about it.
solve that problem.
Yep, I agree. All right, so we're going to start imaging here.
So now they'll pull the guide extension all the way back to the left main,
Right.
so they get the whole picture that they wanted.
Yeah.
Yeah, we pulled it to the guide actually. Let's see. So we got to flush this a little bit more.
Sunil, we got about 5 minutes before they want us to go to the other side.
Yeah. Yeah, so here we're getting into this area of, so we've got some fractures there in the really 360 calcification there. Really nice fractures there. Here,
Not so much, huh? Yeah.
Not so much there, huh?
Yeah.
We'll see what the ostium looks like.
Old Prox's disease.
As we start coming back here, so there's...
Would the panel take an NC balloon here or a cutting balloon? Or a shockwave balloon?
Yes.
So this is nice. So the ostium, I think we got some fractures. So I'm happy there. There's one spot in the Prox LED, I think, where we could use a little more cowbell there.
Let's get a 3.5 by 20 NC.
Yeah, give me a 3.5 by 20 NC. Let's try. We'll take an NC balloon and see if we can get a little more fracture there.
All right. So the plan here is going to be NC and then IVUS after that, or would you just go ahead and stent?
I think NC and then IVUS. I feel like for a left main, if you're going to do a left main, you probably want to make sure that you have good fractures. And you know, we're not in a rush. He's stable hemodynamically. We haven't used a lot of contrast.
Right.
So we just want to optimize the outcome.
We're just hoping to see the stent before you leave. So we got about 4 minutes if we can.
Okay. We can do that.
I mean, I'll stall the other lab a little bit. You know how I am, Sunil.
Yeah, no, we appreciate it. And so we'll take this NC balloon up, maybe take an angiogram, and then make some decisions here.
Because you're going to crank this to 1820, right?
Always, yeah.
Yeah, so, I mean, I don't know. Hari, would you IVUS after that? Would you just say...
After the NC balloon?
I'm 1820, let's just put the stent in.
I think you're okay. Long stent.
Yeah. Because you don't want to do anything
You already have the size and you fractured the vast majority of it.
Yeah.
I think you'll be okay.
You don't want to do anything differently because you're doing a live case, right? You want to do exactly what you would do in clinical practice, but...
We shouldn't force anybody to rush something just because
Absolutely.
we want the picture.
Absolutely.
I think the other teaching point, Luai, is you're going to end up with a long stent, but you have a tapered vessel.
Yeah.
So you need to make really sure that the stent you pick, you can grow to the size of the proximal vessel. Which again goes back to you need the stupid little posters that say the maximal stent size of what you're picking, because you may end up in this case having to underdeploy a bigger stent so that distally you can take an appropriate NC and get it right, but then the stent platform will grow big enough in the LAD, because it's really, really bad to put a stent in that you know is going to not be able to grow to the size of the vessel. Because when they get ISR, you're in real trouble.
So let me ask a controversial question then. We got an osteocalcified LAD. Is there any role about your stent choice here? Is Megatron preferred, not preferred? I'm just curious about the recoil. What's the panel's thoughts about what the stent choice is? Does it matter? Does it not matter?
Going up. What stent do you want? Like a 48?
Talk amongst yourselves.
Okay, so this is 18 here.
Yep.
20?
And that's a 3.5 or 4.0?
3.5.
3.5. Down?
If you have good preparation, it doesn't matter.
Doesn't matter. So if you have good prep, what you choose as a stent is probably not going to matter. So, and that's good prep by OCT or IVUS, right?
Put the wire back in the circuit.
I think.
We're going to put the wire back in the
Seems
circuit
like if you
shortly, and then we're gonna
angiographically
stent. That's
prep,
18.
you're going to recoil more often.
Yep. Down.
Okay.
All right. So, Luai, you want to talk about stent strategy here?
So our plan is to do 135 by 38 from the mid to the prox LED and that's me. Okay.
Watch
That's okay.
your wire. That's all right.
And then the second stent will be hopefully a Megatron that we put in at the top. And I think Megatrons are kind of nice, or any dedicated left main stent would be nice. And so that's kind of where we're at. Thank you.
So 38 from the mid to the prox, is that what we're saying? And then
I think so, yeah. And then
Gotcha.
maybe the Megatron for the ostium into the left main.
Gotcha. Okay.
Yeah.
Yeah, he pulled the wire, and amazingly, he rewired it. People really need to
just wanted to
relax
show you how
about
we could
losing
do it.
wires. Be confident in your ability to manage and deal. Nicely done, Luai.
Thank you.
I would blame Sunil for pulling the wire, though. I'm sure he's the one who did it.
Yeah, it's always the back end.
We just want to demonstrate how we could rewire it easily here.
We're going to
Exactly.
say above it.
All right, so now we're going to wire the circumflex.
While they're doing that, I have a question for the panel. This is something we've struggled with in our practice. My practice has been is when I stent provisionally from either the LAD or the circ back into the left main, I never open the side struts into the other vessel unless there is compromise of some sort. But I have partners who will routinely rewire and do a kissing balloon inflation. What does the panel think of that situation?
Let's get a 3.5 by 38 synergy, please.
3.5, 38 synergy.
I'm going to end up answering all the questions. Sorry, I'm talking too much.
Bill, you're not talking too much. It's my job to tell you.
I would just tell you is, what's the benefit of opening the struts?
Exactly.
All you do is increase the risk of restenosis, and the whole point is you're theoretically making access to that vessel later down the road easier. Deal with that when you have to deal with that, if you have to deal with it. So I do not routinely, I don't go ungel vessels for fun.
Same here.
I do the same thing. You look at the side branch to see how it looks, otherwise you're just changing the geometry of the initial stem.
So we'll have a talk with your partners. They're pretty well-known people, but, you know, we can fix them. Don't worry. Don't worry.
Yeah, same here.
We send one of them away to Henry Ford. But
I mean, I agree with what the panel's saying. I mean, I usually don't routinely do any kind of kissing balloon or anything unless there's a slow flow or the angiographically looks very, very severe. Usually I just leave it. You know, Don Bain was famous for saying all side branches come back. So
A bit more, Aaron.
all right, good.
Good.
So we'll take this.
So let's take that 3.5 by 38.
So we're going to go ahead and position the stent here, and then you can go to.
We listen to Dr. Naidu.
I have
Our-
the 3538 synergy stent. It expires in 2026.
Sunil, they're giving us a hard stop, if that's all right with you.
Okay, great. Well, thanks again for the opportunity. Really enjoyed the discussion. And again, congratulations to the organizers on another successful SIF. We're all done. We'll show you the final results here. So, Lua, do you want to go ahead? So it was very challenging to deliver stents into the LAD. I think that calcified nodule at the ostium there was what was really hindering us. So I think, you know, even trying to modify that was very, didn't really help much. So I think a combination of, you know, buddy wires and guide extensions, we're able to deliver a 3538 to the LED, and then a 4024 Megatron to the prox ostial LED back into the left main, and then proximally optimized with a 508 NC balloon. And then, interestingly, so here's the delivery of the stent. So go ahead, Luai.
Yeah, so we had to use a buddy wire and a telescope and a you know, guide extension to be able to deliver that. And then there's still a little spot in the middle of the stent you can see there that's not fully expanded. We got it cracked out ultimately. And then we put in back the wire in the circ. Still needed a telescope to be able to deliver that 4.0 Megatron. And came back as much as we could with overlap. And then nice expansion there. So we were satisfied with the distal edge. So we went up 3.5 to 20, and then we took a 4.0 to 20 in the ostium of the LAD and the left main, and then we took a 5.0 to 12 in the left main. It measured 5.0. We wanted to evaluate the circ. You can see the ostium is a little bit pinched there. So we ended up doing a DFR of the circ, and it was 0.97. We put in a wire in the circ, gave quite a bit of nitro and waited, and there was really not much of a gradient. And then we IVISed the LAD and the left main, and we got areas above 6.0 in the mid LAD, around like 8 or 9 in the ostium of the LAD, and around 12 for the left main.
Great job, guys. We're going to let David make a comment, and I'll let you finalize it. Dave?
Hey, Sunil. First of all, outstanding job. As we've grown accustomed to these kinds of results from you. But I will say for everyone on the panel, everyone in the audience, when going transradial on these very complex lesions was still considered sort of interventional heresy. We used to say, but it's multi-vessel, it's left main, so I'm going to go transfemoral. It was actually Sunil V who popularized and gave credibility to the ability to go transradial on these complex cases. And so, Sunil, I thank you for, over the years, the contributions in live cases you've made to not only to our meeting, but all meetings. But this is a terrific result.
Great job, guys. Great job.
Thanks
All
so
right.
much, Dave.